Okay, so we're going to get started with week 5's lecture. This is my third time recording this, so let's hope this one actually will submit to YouTube. So this chapter is going to get us into looking at the actual EKG. So by the end of these slides, you should be able to determine if the rhythm is normal. That's it. We're not going to go any further. For those of you that have already had prior EKG coursework, it'll serve as a really nice review. Others, you're going to want to pause multiple times as we move on to the different sections. I don't think this is going to be a lecture you're going to want to listen to in its entirety. So when we talk about what is normal EKG, it means looking at the paper and recognizing that all of the waveforms, the heart rate, everything is within what we call normal parameters. So that's the focus of this chapter as we move on. The lectures will be shorter because we'll be dealing with smaller subsections. So some of the material that we want to make sure that we highlight, that we're going to go over, is when exercising with the electrodes on, a lot of times there's artifact where you're not able to get the computer system to give us a calculated heart rate, so we're going to have to be able to manually do it on the paper. So I'll show you 3 different ways or techniques at determining heart rate quickly while someone is exercising. The second thing we want to take a look at is understanding where the 10 electrodes go on the chest that produce 12 different views. So 10 electrodes giving us 12 views or 12 photos. 6 of them will be in the frontal plane and the other 6 will be in the horizontal plane. So understanding, the frontal versus the going right through that horizontal transverse plane. Understanding really where those electrodes are placed and why they're placed where they are to give us a different angle of the heart. We'll talk about something called the hexaxle reference system, and at first glance it can look intimidating, but I do feel like it's an image that you're probably going to want to bookmark in your textbook because it serves as a very good reference point, as it states, hexaxle reference system, at understanding the leads and where in the heart those leads are giving us that nice view from. We'll go through each of the waveforms, what their timing should be, both in millimeters and in seconds, and determine what we call axis deviation. So it's a lot of stuff. So in a nutshell, when we have the SA node, which we call the pacemaker of the heart, that SA node is located up in the atrium, the right atrium, that is going to send the signal for the cells to depolarize. So once the SA node gets excited, it's going to send the conduction down to the AV node, and we want to be able to tell when the heart is contracting if the beats that are happening that are originating in the SA node, sending the action potential down to contract the myocardium if everything is in what we call normal rhythm. So we will look at the waveforms, and when we talk about ECG versus EKG, it's the same thing, right? EKG is German, ECG is English. I say them both. It doesn't matter what you refer to it as. So we're going to start with the word isoelectric. Isoelectric is that horizontal line, the baseline. So when you're looking at an EKG, that flat line means there's no electrical activity. So you've seen a flat line, right? Someone is pulseless, unconscious, right? Isoelectric. But when we're just looking at an EKG, the isoelectric, no electrical activity, we want to decipher between a positive deflection that's moving upwards and a negative deflection that's moving downwards. So isoelectric, flat, positive versus negative. When you're looking at the waveforms, anything that's measured vertically in height is done in millimeters. Anything measured on the horizontal axis is done in seconds. So this is what the paper looks like. We have bold lines, and inside the bold lines are fine, small lines. The little baby boxes are 0.04 seconds. So one bold box is 0.20 seconds. You did the math, right? So there's 5 baby boxes at 0.04 seconds, one bold box at 0.2 seconds. That's a really important thing to jot down because it's going to make counting the EKG paper much faster when you realize that the bold boxes are in the horizontal plane, 0.2 seconds. And then again in millimeters, there are 1 millimeter boxes and there's 5 of them, so one height of one bold box is going to be 5 millimeters. Then you see the little hash marks along the bottom here of the paper. That's just telling us this is a 3-second strip. In a minute I'm going to ask you for a 6-second strip. So those hash marks are really helpful for letting us know time of the paper so we can do a quick 6-second look at somebody. So the 6-second look is a really common in a rehab setting when someone's exercising, to get a 6-second clip and be able to estimate heart rate that way. So these grid lines are standard, they're for accuracy. Again, a little box is 1 millimeter in height and 0.04 seconds in the horizontal. Speed, I'm going to talk very quickly about the speed of the paper. The speed of the paper is going to just be set. We're not going to mess with the speed of the paper unless we've been told otherwise. So don't change the speed unless there's a reasoning behind changing the speed at which the paper is coming out. We also, though, want to make sure that things are calibrated, and most newer machines will do the calibration, the communication between what the electrodes are recording and how fast that paper is coming out. So the calibration is going to look like this photo, right? So standard calibration is going to give you this nice horizontal pattern on the grid paper, and half calibration is going to look like a half calibration. I'm not going to ask you questions about calibration, but just, I realize that when we're using any of the equipment in the lab, we want to make sure that they're well calibrated. So wave amplitudes and automated cuffs. So what we know about automated machines is that they don't often work when people are exercising, and I say that's an important thing because people also ask about manual versus automated blood pressure. When we're in an exercise lab, we're going to do everything manually because the motion of the body oftentimes interfaces with the machine. So an automatic machine is typically going to struggle in determining what those R waves are. And the same thing happens with heart rate. So yeah, we have the electrodes on the chest while the person's walking or running on the treadmill or the bike, but being able to find those R waves realistically can lead to insufficient information, which is why we want to be able to do a really quick heart rate check when needed. Right? So we're going to do a manual blood pressure, and every now and then when needed, have to do a manual heart rate check. So if we know that the standard 12-lead printout, 12 seconds long, right, with all 12 leads on there, there's going to be 3 lines I'm going to show you, I think on the next slide, 3 lines showing you the different leads, and then usually 1 rhythm strip. A rhythm strip is 1 continuous EKG. So we have the 12 leads showing us all 12 views, and then a continuous rhythm strip along the bottom. In most clinical phase 2 cardiac rehab programs, you're going to usually only use a rhythm strip, so either 2 or 3 electrodes on the patient's chest, and it'll be a continuous, usually lead 2. So this is what the printout's going to look like. So we have Roman numeral 1, 2, 3, and then the second column are the augmented leads. So augmented right, augmented left, and augmented foot. These 6 leads are considered augmented leads are derived from Einthoven's triangle 1, 2, and 3. And then we have our chest leads V1 through V6. And then along the bottom is that rhythm strip. We can tell a system what lead we want to choose. Most commonly, it's going to be lead 2. We talk about lead 2 all the time. So Roman numeral 1, 2, 3 gives us Einthoven's triangle. Our augmented leads are derived from those limb leads. So these 6 leads come from 4 electrodes. We call those the limb leads. And then we have V1 through V6. These are our chest leads. So before we get into actually understanding how I just quickly told you all about 10 electrodes giving us 12 views, let's stop and take a look at how do we calculate heart rate. I'm going to go over 3 methods of heart rate calculations. The first one is one that I use most commonly. It's called the dark line method. Not a fancy name. We're using the dark lines on that pink paper. In order to use the dark line method, you have to memorize the series of numbers. And as silly as it sounds, I'm going to say just put it to a jingle, kind of a little tune in your head, so you can memorize 300, 150, 100, 75, 60, 50, right? So 300, 150, 100, you just got to memorize. You got to count backwards in this order. We very rarely ever get to 44 or 38 in an exercise setting with someone's heart rate getting that low, but it would go down that low. So how this works, before reading this slide, I want to just show you. So we need to find an R wave that happens to be printed. Here's the R, right? So P, Q, R, S, T. The R waves are the spike. So you want to find an R wave that is printed on one of the bold lines. So here's the pink paper with the bold lines. Obviously in this example, they're all they're all being printed on the bold lines. But that's going to be our starting point. So that star serves as where we're going to start counting. I don't count that as 300. I'm going to count the next bold line as 300. Now I'm going to count the bold lines until the very next R wave appears. So here's my R wave printed on a dark line. So this line is going to be 300, 150, 100, 75, and now we have the R wave appears before the 60. So we're going to estimate that this heart rate is somewhere between higher than 60, lower than 75, right? So it's going to be kind of in the mid-60s. Let's try one of them down here. So let's start on this one right here. We're going to start on this R wave. So this is 300, 150, 100, and this lands right on the 75. So this method is not about counting boxes. It's not about reading and interpreting EKGs. It's simply counting the space between two R-to-R intervals what the timing is. So now we estimate this bottom one was spot on 75, this one was in the mid-60s. That's what we call the dark line method. So it's one way of calculating heart rate when the machine fails us in a clinical environment where you want to get a quick heart rate. So again, that's the dark line method. The second method requires a calculator. Let me pause before I get into the 1500 method. This is the clinical tip. So during exercise, how would we use this? So let's say we prescribe a patient a heart rate between 96 and 102, and you realize that the machine is not calculating the heart rate very accurately. So we do this method of calculating using the dark line method. So we find the first R line on that dark, we count, and we notice that the heart rate is now higher than 102. So you've got to make that clinical decision and say, okay, the intensity that this patient is working at is higher than his heart rate range. I need to lower the intensity. Does that make sense? So we're checking the heart rate for many reasons. For one, in the exercise environment, we're checking this to make sure that the intensity is adequately prescribed. The second method is the 1500 method. This is the method that might make the most sense for you, but it takes a little bit of time. You got to be really good with counting the little boxes, and you probably need a calculator. So the constant number is 1500. That's what you're going to divide. That's kind of your magic number for division. What are you dividing by, right? So you got to count how many boxes. So for this one, it doesn't matter what R wave we count. We're just simply going to count the boxes between two R to R. I want to bring your attention to this, in parentheses, regular rate. So a regular EKG means that the R to R intervals look nice and kind of like a metronome. They're very regular. An irregular rate, which we'll look at later in weeks to come, means someone's in an irregular rhythm. So we're only allowed to use the 1500 method for a regular rate, which will probably be your heart rate right now. So how we're going to do this is you just pick any two R to R intervals. It doesn't matter which ones. We are going to count the little boxes. So as you see, it takes a good set of eyes to do this because the boxes are really fine. You're going to count how many baby boxes. And there's 17 baby boxes here, and you're going to take 1500, right? So you're 1500, 17, you do the division, you get 88 beats. This is going to give us an estimate between each R to R interval. Therefore, we can make that inference that this heart rate is approximately 88 beats per minute. Makes sense, right? The problem is again, you got to count it fast and then pull out the calculator and do your math. This third method, and the last method I'm going to talk about, is now for an irregular heart rate. So remember, I talked about irregular heart rate. At first glance, you notice that this rhythm looks very different from this rhythm. In this rhythm, without knowing anything about the waves, you notice these R waves, right? The spike is the R wave, is nice and regular looking. We fast forward to this EKG, and we notice that the R wave is very irregular. It's not happening in a metronome. It's not happening in a cadence fashion. This is the irregular rhythm. This is an example of atrial fibrillation. Don't worry about that. So in order to do a 6-second method, we are going to take a 6-second strip. I mentioned that earlier about the 3-second or 6-second, the little hash marks on the paper. We're going to take a 6-second strip, and we're going to count how many R to R intervals we have in that 6 seconds. So here we have a 6-second strip. Here are R to R intervals. We have 8 of them. We have 8 cardiac cycles. We add a 0, we get 80, right? 8 out of 0, we get 80. It's no different than doing a fast pulse check, right? You can do your pulse 15 seconds times 4. right? You can do 6 seconds and add a 0. You can do 10 seconds and multiply by 6, right? There's all these different ways you know this of how to calculate heart rate. For an irregular EKG rhythm, we're going to do 6 seconds, count the R to R intervals, add a 0, 6-second interval. You might want to pause, stop, rewind, and make sure that these 3 methods make sense to you. Okay, I'm going to keep moving on. The next thing I want to talk about is how 10 electrodes give us 12 views. So we call this Einthoven's triangle. Einthoven's triangle, we put 10 electrodes on the body and we get 12 photos. 6 are called limb leads, and the other are 6 chest leads that go right directly on the chest. And then with the placement of the 4 electrodes that are considered our limb leads, right arm, left arm, they go just right under the clavicle, that subfossa area in there. And then the legs, we'd put them on the legs if someone's just lying in supine, but because we're exercising, we're obviously not going to put wires down on the legs. We're going to pull them up to the torso. There's a few different areas between the ribs and down that we can place those leg leads, even though they're not on the legs. The right leg lead serves as a ground, even though we say there's 4 electrodes. That right one, so the right leg is a ground, so we're really looking at 3 electrodes that are going to give us these 6 different leads. Leads are photos, views, pictures. This table shows you all 10 electrodes and where they need to go. So the right arm, left arm go right under the right clavicle. There is that subclavicular fossa. The legs, again, depending on, I'm teaching you exercise stress testing, so they're going to go up on the torso. I like to put them higher than the belly. I feel like the more belly fat someone has, the more artifact they have. Artifact means unable to read the EKGs. So I kind of like them closer up on the ribs, kind of the lower ribs. That would be right arm, left arm, right leg, left leg. And then we have the V's, these precordial chest leads, V1 through V6. They go right on the other side of the sternum. So you're going to count the interclavicular spaces. So on your own chest, feel the space between each of those clavicles, go all the way down to the 4th intercostal, and the sternum is in the middle here, so you actually have the zipper. So this is the sternum. On the 4th intercostal, that would be my right side, and then my left side, that's lead 1, V1, V2, right? So 1 on the right, V2 on the left, and then the rest go all the way over to the left. So they're both on the 4th intercostal. V2, right on the 4th. V3 is a tricky one. Don't do V3 until the very end. Come back and do V3. Let's skip V3. V4 is now on the 5th intercostal, and it's going to be midline, the midclavicular line. So midclavicular line all the way down to the left, on the left side to that 5th. So it's going to be right under the breast is V4. V5 is right to the side of that space on the anterior wall, and V6 is going to be at the mid-axillary line under the armpit all the way down to the side, so it's right on the left side. You're going to come back and put V3 right between where you put V4 and V2. That's the easiest way of doing it. So they go right under the left chest. We need to also make sure that the skin is absolutely clean, so you're going to take rubbing alcohol and you're going to abrade until the skin goes red, right? Irritate it. In some clinics, they will give you fine grade sandpaper. You're going to sandpaper on the skin. You want to make sure that this all helps to make sure the sticky part of the electrode is going to stick on the person's skin. As they're exercising, the sweat can make the electrode come off, and then you got to quit the test, and it's really a big disaster. So not only EKG placement of understanding the landmarks, but skin preparation is very imperative. So we would stop at this point and go down to the lab, and you would show me that you know how to find all of these landmarks. The left breast and chest will get in the way, so you want to be careful to go right under that left side so we get really nice, clean EKG readings. This is what Einthoven's triangle looks like. So remember I said it's derived from 4 electrodes. On the photo I only show you 3 because remember the right leg is a ground. So we have right arm, left leg. Leads 1, 2, and 3, they intersect. right? So, they're not just showing you the top of the heart. This is just a fictitious way of you understanding the vectors on which that current is traveling from a positive, right, the negative and positive. So we have lead 1, lead 2, and lead 3. This is what makes up Einthoven's triangle. Einthoven's triangle is really important to understand, right? So the moving from one electrode to the next is what gives us these 3 limb leads. This is what the 3 leads look like on paper. So this is all the exact same heartbeat, but the amplitude is going to be different because it's moving through a different area of the heart. As you notice, lead 2, I talk about lead 2 a lot. Lead 2 is a really nice, clean view of the left apex of the heart. How do I know that, right? If you go back to what Einthoven's triangle looked like, right? Lead 2 is going to go straight down. Remember that these would be intersecting. It's not showing you the intersecting. But lead 2 is a nice angle straight down, which is why we're going to oftentimes look at lead 2. Lead 1 amplitude's a little smaller, then lead 3. Lead 2 is a really nice one. The unipolar, or what we call augmented vectors, they give us another 3 leads, augmented right, left, and leg. There are 3 more photos, and they're best viewed in this thing called the hexaxial reference system. Hexaxial reference system, when I show it to you, is going to look a little confusing, but I know it's going to be a photo you're going to come back throughout the class because it really helps us to understand the anatomical breakdown of where the electrode placements go. So we're going to identify the negative and positive of each pole, be able to identify the regions, understand again positive and negative. Let's just look at what it looks like. So here's what we call the hexaxial. What I want you to look at is the red lines. So here we have red line, which is lead 1. It's going straight along to the left side, right? So that's lead 1. Lead 2 comes down right through the apex of the left ventricle, which is why we like this one, right? It's giving you a nice view of that ventricle. Lead 3 is shifted a little bit to the right. So we have all 3 limb leads, Einthoven's triangle limb leads, Roman numeral 1, 2, and 3, are left side. Straight to the left, on the angle to the apex is lead 2, and slightly away, shifted to the right, leads 1, 2, and 3. The other thing you want to look at is where are the augmented leads. Right down here in the middle is augmented foot. Another good one, we're going to look at this one a lot, augmented foot. However, AVR and AVL are way up away from the heart. We don't have much stuff happening up here, but they do serve as a good reference point, right? Especially AVR is almost exact opposite to what we're seeing down here at lead 2. So this is showing you kind of the full 180. It's like a bicycle tire with these spokes, right? It's, we got the SA node in the middle, and we've got all of these ranges of all of these different views. So here we have 6 views. We have a view straight on lead 1, the apex of the left ventricle 2, shifted away lead 3, our foot straight down the middle, and then we've got augmented right and augmented left. Those are the 6. The other 6 we call chest leads, or the word precordial. These are much simpler to understand. So you might want to rewind and listen to Einthoven's triangle. There's some great YouTube videos that talk about Einthoven's triangle. The chest leads are simple. It's V1 through V6. Really, there's a negative pole and a positive pole. It's kind of like an imaginary line going right through the center of the heart to get to the positive pole. So this is what I mean. So we've got these electrodes, right? V1, V2. Each of these leads, each of these photos have their own tracing on the EKG. Is that right? So that makes sense. That's what makes it much easier to understand these, right? Lead 1, 2, 3, all the way through. It's a cross-sectional, that horizontal transverse plane of the heart. So I feel like, lead 1, you're right at the right side, looking straight to the back of the heart. V6, all the way on the left side, looking straight through, right? That transverse horizontal plane. So we put on 10 electrodes to get the 12 different views. So it's like putting me in the middle of the classroom and having students pull their cell phone out, 10 students, 10 electrodes, pull the cell phone and take a photo of me at the same time, but it's a different angle. And that's what these electrodes are giving us, a slightly different angle of a direction. So what we're going to see in the EKG tracing is a normal cardiac cycle, or one heartbeat is what we call one cardiac cycle. I want you to be able to tell me as we move in the next few weeks, is it a normal sinus rhythm? So all of these things on this slide must be present in order for us to see that it's normal sinus rhythm. So it means that we have a P wave for every QRS. Right? So, right, here's a P wave and a QRS. So let me go, before I show you that, right? So we've got the P. Here, this would be the Q, R, S, right? So this is the Q, R, S, and the T. That's one heartbeat. So in order for us to have a normal cycle, we want only one P wave. You don't want more than one P wave. You don't want more than one QRS. So P and a QRS. Then in lead 2, Roman numeral 2, you want to make sure that the P is positive. It's not inverted and flipped upside down. And the R wave must be positive as well. If either of them are negative, in lead 2, we don't have normal sinus rhythm. We have something else we'll look at later. Then we want to look at that goofy AVR. Remember AVR, if I go back to the hexaxial system, AVR is up this way. AVR is always, if it's a normal, healthy heart, the AVR is always going to be inverted and negative. So on this bullet, I say the P wave and the QRS should be negative, inverted, right? They should be going below the isoelectric line. That is fine, right? So in lead 2, they need to be positive, and AVR, they need to be negative. You have to calculate the heart rate. It must not be bradycardic, below 60. It must not be tachycardic, 100 or above. And then the last thing is axis deviation, which I'll do at the very end. It needs to be what we call the normal axis. We'll get to that later. So all of the waves need to be normal for us to give it the NSR, normal sinus rhythm, right? So normal sinus rhythm. So we want to take a look at each of the waveforms that we see, right? The P, QRS, and T. Starting with the P wave, the P is the first positive deflection. When we count, its normal height should be about 2.5 millimeters in height, so not very tall. And the width is really important. The width of a P is going to be 0.08 to 0.12 seconds. Classic, that's all you need to know. What is the P wave? The P wave is contraction of the ventricles. It starts up in the SA node. So the SA nodes gets excited, that action potential begins, depolarization happens, atriums contract, we get a P wave. Then we have the PR interval. This is a very important thing. The PR interval is the distance from the beginning of the P wave to the beginning of the QRS. This needs to be no more than 0.20 seconds. So just to show you again what that looks like, here's the beginning of the P to the beginning of the QRS. We're going to count those boxes, and we want the PR interval to be no greater than 0.20 seconds. We will talk later as to why this is important, but the PR interval is another thing we're going to count. This is the Wiggers diagram. I'm not going to ask you much about it, but I do have a YouTube clip on here you can watch. It's very confusing if this is your first class looking at a full cardiac cycle and all the stuff that happens. This class has got one focus, and this class is only to be able to understand the electrocardiogram. The bottom here, these are the heart sounds. If we had a stethoscope in our ear, we'd be listening to lub-dub, right? These are the heart valves opening and closing to let just the right amount of blood to go through, because up here we have pressure changes. We have the aortic pressure, the ventricular pressure. We don't need to know all of this. Again, I just want you to know the cardiac cycle in relation to the electrocardiogram. So as these valves open and close, letting blood flow through those different chambers, and the action potential is traveling, depolarization is happening, we're going to have a heartbeat. The QRS is tall and skinny, right? So the QRS, Q, right, is right kind of at baseline. R is the spike, and S. The thing that's important with QRS is that it should be skinny. When you count the boxes in the horizontal plane, it should be 0.10 or less. If it's wider, we're going to look at what that means later. But a good normal QRS is skinny. Here, right, is the QRS. So we're going to count those boxes, and this is less than 0.10. PR interval, we can count the boxes. The PR interval begins at the beginning of the P all the way to the beginning of the QRS, and that should be less than 0.20. You do the math, and it tells you right here, when I count these baby boxes, it's 0.16 seconds. seconds. If I'm going to take a look at the QRS, we want to be aware, let me go back here. In this photo, you see a little divot down. You see a little tiny negative deflection. That's the Q wave. Some people, when you hook them up to the EKG, the Q wave may just be isoelectric. That's fine. The same thing can happen with the S. It could be isoelectric as well. They may not be negative, but you'll notice that this is still going to be the R wave. So after the P wave, that thing that happens after, that initial inflection, first you have the Q, after the Q is the R, and anything after the R is called the S. Again, the shape of it all could be a little bit different. When you see textbooks using a lowercase, it's signifying that the wave is less than 3 millimeters. That's simply what the lowercase is meaning. So on this photo, let's count the QRS. So we are going to count those little baby boxes in between the width so we can tell if it's normal sinus rhythm. Right? We'll look in weeks to come as to what would be considered abnormal. So in this diagram, the QRS complex is 0.10 seconds, which is perfect, which is what we want it to be. V1 through V6, small R wave is common to be seen, and as you go through those V leads, it's going to change, right? So V1 on my right side to V6 over here on my left side, a small R wave, a septal R wave, and then you're going to have a negative deflection. It will look like a small R and an S. Over here in V6, we often see a small negative Q wave and a positive deflection R wave. And these couple slides might be a little confusing. We can come back and revisit them. The ST segment is something that we will look at a lot in this class because the ST segment is going to let us know about ischemia. So when we talk about the word ischemia, we're talking about symptomatic during exercise. So someone who's shortness of breath, they're getting labored, they're getting chest pain. In healthy people, the ST segment should be isoelectric, just nice and flat. However, there's something called a J point where the QRS complex ends and the ST segment begins. And we would begin counting this in millimeters of elevation. And as we count elevation, it's indicating disease, ischemia, infarction, bad news, right? Again, we want that ST elevation to be totally flat, but when you have a shift in the ST segment, something is happening. So the first photo is ST segment isoelectric. Hopefully we like that. Here, however, we have ST elevation, and here we have ST depression. These are not ideal, right? Something is happening. What is the difference between ST elevation and ST depression, right? You notice that it's not isoelectric. Our job is to count how many millimeters, right? So each of those little boxes, we're going to count. So we're looking at ST segment depression. What's happening is the electrical signal is taking longer to move through the myocardium. Think about that. What would delay the action potential from carrying the signal? The delay is going to be disease. So coronary artery disease, myocardial injury, dead cells, necrosis from a heart attack. It's no longer able to conduct, or it's delayed in conducting. So during exercise testing, if we see ST segment depression, it is a sign that it's an old infarct. It's an area where there's dead or not very active cardiac cells. So on an EKG, we're going to be able to tell what location, where anterior, posterior, or inferior the MI happened from. Exciting stuff, right? So we also can look at ventricular hypertrophies and bundle branch blocks. When we look at ST elevation, this is telling us right now acute impending doom, right? That once we start seeing elevation while exercising, this is cause to stop, get help, take the stress off the body because ischemia is happening. If the person is symptomatic and ischemia persists, we are going to potentially end up in a full-blown injury, myocardial infarction. So that's what we know is a myocardial ischemia, myocardial elevation. We'll look at more details later. The last wave is the T wave, right? So P, Q, R, S, and then we got the last hump, which is the T wave. The T wave is simply in a lead 2 is going to be positive, but it's simply just repolarization because now the ventricle's ejected the blood out of the ventricle, right? The QRS has happened, and now the T wave is just repolarization. You know this as diastole. Note, however, that if the T waves are inverted, that usually it's a sign of something going wrong. There's usually more ischemia present. Very infrequently, you're going to see a U wave, which is after the T wave. I'm not going to talk much about the U wave, but you might see another little hump on that T wave. We'd call that the U wave. So here we've got the P, right? We've got the PR interval, right? That distance between the beginning of the P. Here's the Q, RS. This is the ST segment, which is nice and healthy, isoelectric. And then we've got the T wave. Excuse my dog barking. Cooper, shh, stop barking. No. Okay, moving on. The QT interval is something that I'm not going to ask too much about, but the QT interval provides the ability to look at a little bit of prognostic value. So to measure the QT interval, it begins from the start of the QRS to the end of the T wave. A normal QT interval is right around 0.44 seconds, which is a lot of information in this lecture, or half of the R to R interval, which we'll talk about that a little later. Don't worry too much about doing Bizet's formula. I'm not going to ask you about that. Just understand that the QT interval begins at the Q, goes all the way to the T. We're going to count those boxes, and ideally about 0.44 seconds on the horizontal line. Now, patients that have elongated QT interval are at risk for sudden death. So this is something that with avid exercisers, we really want to take a look when we're stress testing healthy people to look at the QT intervals. Anyone who has prior history of ventricular any type of tachyrhythms, the QT interval again can be somewhat prognostic, kind of like a little bit of a crystal ball to take a look at what needs to be done if someone has a long QT. The very last thing we're going to do is something called axis deviation. Axis deviation tells us the direction, the vectors, or the direction that the depolarization is happening. So the SA node is up in that atrium, and it's going to move down in that diagonal plane towards the apex of the heart on the left, right where the heart is sitting in the chest. There are different reasons why the vector could be displaced. So in healthy hearts, obviously the vector is going down towards the left. We want to look at someone's axis because there's a reason for the axis to be shifted left or right. So in order to determine axis deviation, we're going to look at that hexaxial reference system that I brought up to you earlier. We're the hexaxial reference system that does Einthoven's triangle, lead 1, 2, and 3, augmented, AVL, AVR, AVF. And I'm going to show you a really quick and easy way of doing the axis deviation. So again, what is axis deviation? Axis deviation is the direction that vectors are traveling in. Okay, so the flow of that of the current that's moving, that's what the electrodes are recording. So we want to be able to look at the depolarization in healthy people. It's going to continue to that negative, to that left side of the chest. We have 4 quadrants. Okay, so we have 4 quadrants of the hexaxial system. Here is the same photo I showed you much earlier, but now I've got the quadrants lifted on here. Remember, here's lead 1 to the left, lead 2 down to the apex, lead 3 slightly to the right, and AVF right down the middle. These are the leads we look at the most, right? AVR and AVF is up here. Here's my normal quadrant. That's where we want the axis to be for us to have normal sinus rhythm. This is the right quadrant, shift it to the left, and this really odd one is what we call extreme. So in order to figure this out, to make this very easy, we're only going to look at 2 leads. And the 2 leads are going to tell us which one of the quadrants it falls in: normal, right axis deviation, left axis deviation, or this extreme, otherwise known as indeterminate. So in order to do this, I want you to write down or highlight lead 1, Roman numeral 1, and the augmented AVF, right? So lead 1 and AVF. So over here on this picture, here's my lead 1, and down here is AVF. So those, when you're looking at the 12 lead on the paper, you only look at lead 1 and AVF, and what are you looking for? Very simple. The only thing you're looking for is if the ECG tracing in lead 1 is positive, right? The P wave is positive, the QRS is positive. Do the same thing for AVF. You don't have to count boxes. You don't have to be able to determine, if the rhythm is irregular. All you're looking for are the deflections positive, right, above the isoelectric line. So lead 1 and lead AVF. If lead 1 is positive, you put a thumb up. If lead AVF is positive, you put a thumb up. Both of those leads are positive. Guess what, guys? We're in what we call normal axis deviation. Right? Positive lead 1, positive AVF. However, if one of them is negative, then we're going to drop to a different quadrant, right? So positive lead 1, positive AVF, we're in the normal quadrant. If lead 1 is now negative and lead AVF is positive, we're going to be shifted to what we call right axis deviation. If it's the inverse and your lead 1 is positive and your AVF is negative, it's shifted to the left axis deviation. Easy one. If both are negative, right, it's flipped up to the indeterminate extreme axis deviation. So to practice this, here's 2 examples. So here's the, this is not a 12 lead. We just got the 6 leads on here. We've got Roman numeral 1, 2, 3, augmented, the 3 augmented. So here's my lead 1. It's labeled. So here's lead 1 and here's AVF. So for this example, so don't worry about the bottom example for now. Lead 1 is positive. You would agree that's a positive. Lead AVF down here, that's positive. So lead 1 is deflection is above the isoelectric line. Lead AVF is above the isoelectric line. Looking at the one below here, lead 1, again, positive, QRS, and AVF is a positive. So again, we have a normal axis. If we want to look at a different example, here is a lead 1 that's positive, and this one is a full 12 lead in my eyes. Down here is my AVF. It's hard to see on the screen. You all notice that this is negative. So I have a positive 1, lead 1, and I have a negative AVF. This puts us in left axis deviation. What puts us in left axis deviation? Simply because the deflection is positive in lead 1, but down here it's negative. What is that telling us? It's the direction those vectors are traveling through those cardiac cells. So for something, we don't need to worry in this class about the pathophysiology as to what's causing the shift in the axis. I just want you to know it on the EKG tracing. Don't worry about the pathology. And then here is a negative lead 1 and a positive AVF. So axis deviation, when we practice it, it's really not that difficult to see the difference between them. So I'm not going to read all these to you because you kind of got them. So I'm hoping that for the discussion post that you're going to make, there's a lot of content. I want each of you to have completely different discussion posts with different content to really help each other be able to get a grasp for heart rate calculations, calculating the PR interval, understanding the QRS should be 0.10 seconds, the electrode placement, the Einthoven's triangle, axis deviation, lots of things to write questions on.